Continue our discussion about different types of crashes. So rollover crashes, um, the large trucks and SUVs are actually more prone to rollovers because they have a very high center of gravity. And then injuries tend to depend whether or not the passenger was restrained. The most unpredictable types of injury patterns are caused in rollovers when, and it doesn't even have to be all of, but when at least one of the passengers are unrestrained, they tend to become a flying object and collisions happen that you wouldn't really expect. The most common life-threatening event is either a partial or total ejection from the vehicle. Even when restrained, though, keep in mind passengers can still sustain severe injuries. And then rotational crashes, these are spins, very conceptually similar to rollovers just because they can be extremely unpredictable. But the rotation of the vehicle provides various opportunities for the vehicle to strike different objects. And then that rotational force as well does not do great things for your aorta. So this is another high probability of an aortic injury. Car versus pedestrian injuries are often very graphic and apparent, and we kind of get distracted onto those. So we have to be very careful to not get tunnel vision onto what we see and work through finding what we can't see. So you have to have that high index of suspicion for unseen injuries. You need to try and determine a couple of different things to help you with determining how bad the patient is injured. So speed of the vehicle, whether the patient was thrown through the air, what distance they were thrown, what kind of surface they landed on, and whether the patient was struck or pulled under the vehicle in the accident. Look at the vehicle to see if you can figure out what kind of structural damage it has. And then you're going to want to call ALS for any patient that is thought to have sustained a significant MOI, even if you don't quite see what's going on, because again, those hidden injuries can actually be what causes the demise of your patient. Car versus bicycles, you want to evaluate the mechanism the same as you would a car versus pedestrian. You want to evaluate damage to the position of the bicycle and damage to the vehicle itself. Presume that the patient sustained an injury to the spinal column or the spinal cord unless proven by the hospital that they didn't. So we're going to utilize spinal immobilization. You want to also inspect that helmet for damage. That's one thing I didn't mention. Car versus motorcycle. So you can get protection on that motorcycle from a helmet, but it doesn't protect against severe cervical injuries. The helmet adds a lot of weight to the head, so if it is thrown one way or the other, that can cause significant injury to the cervical spine. Leather or abrasion resistant clothing, this will help against road rash basically, but it doesn't do much for blunt trauma because of impacts. And then boots. Collisions usually occur against larger vehicles or stationary objects. When you're looking at the scene, you want to look for deformity of the motorcycle, the side of the most damage, distance of skid in the road, deformity of stationary objects or other vehicles, and then the extent and location of deformity to the helmet. There are 4 main types of motorcycle crashes. So a head-on crash where the motorcycle strikes another object and stops forward motion, while the rider themselves continues the forward motion until they're stopped by an outside force. This could be the vehicle that they ran into, the object that they ran into, or simply the pavement. An angular crash, the motorcycle strikes an object at an angle, so the rider sustains a direct crush injury to the lower extremity between that object and the motorcycle itself. The ejection, the rider will continue to travel at a high speed until stopped by a stationary object, an other vehicle or road drag where they skid along the road surface or whatever ground surface they are on. These cause severe abrasions or road rash, and it can be down to the bone depending on how bad they ended up dragging and what kind of protective barrier they had between them and the surface they were skidding along. And then a controlled crash. This is a technique that riders are taught when they do safety classes. It's how to separate the rider from the motorcycle and let the bike hit an object before the rider hits an object. So this is what they call laying the bike down. Falls. The injury potential of a fall is directly related to the height from which a patient fell. More than 20 feet is considered a significant injury, but it also depends on the size of the patient. The smaller the patient, the less height they have to fall from in order to make it significant. So you can have not only those external injuries with a fall, but it's your internal injuries that are going to pose the greatest threat. People or patients that fall and land on their feet may have less severe internal injuries because the legs and hips may have absorbed much of the energy, but their legs and their pelvis are going to have sustained quite a bit of energy and could have very severe injury to them. So you want to take into account the following factors: the height of the fall, the type of surface the patient landed on, and then what part of that body hit first, and then how did the rest of the body travel. So if they landed on their feet, were they thrown forward or backward, and then again, what contacted when that continued. For penetrating trauma, it's the second leading cause of traumatic death in the United States after that blunt force trauma. Low energy penetrating trauma can be caused accidentally by impalement or intentionally by a knife or other sharp weapon. Many times it's difficult to determine entrance and exit wounds from projectiles in the pre-hospital setting. So what we want to do instead is we want to determine the number of penetrating injuries and then combine that information with important things we already know, such as potential pathway. So we can try to guess where something went in and where it may have come out for the exit wound, and then anything it could have damaged in the path. Low energy penetration injuries are caused by the sharp edges of an object moving through the body and are very close to the object's path itself. Knives may have been deliberately moved around internally, so they cause more damage than that external wound suggests. Trying to determine the length of that object can often help with determining the severity. In medium and high velocity penetrating trauma, the path of the projectile, usually going to be a bullet, is really not all that easy to predict. Bullets have different mechanisms of action. When they end up being fired, they may flatten out, they can tumble around, they can even ricochet off of pieces of the body before they end up exiting. The path that a projectile takes is called its trajectory. If the projectile ends up breaking into more than one piece, that's called fragmentation, and that will often result in a different and worse injury pattern. So when a projectile collides with the skin, you actually get a cavitation that precedes the bullet or projectile, and that causes an area that's bigger than what the actual projectile is itself, because you have rapid changes in tissue and fluid pressure. And then the actual path of the bullet is forming a permanent cavity. The temporary cavity that you end up getting because of that cavitation, that stretching of the tissues, that tends to decrease and the permanent cavity, the actual path that the projectile has taken, ends up remaining after that. Here's the picture. After that projectile is through. So you can see the blue is that temporary cavity. It actually precedes the bullet and is because of that force of energy. And then the red through the center is the actual path of the bullet that's forming the permanent cavity. And you can see that that projectile is tumbling in there. It's not just going straight through. The relationship between the distance and severity of the injury is there, but it also varies depending on the type of weapon that's involved. Air resistance, also often called drag, slows a projectile and decreases the depth of penetration and energy, so it reduces damage. So the further away the weapon is from the patient, the lower that potential energy is. The area that is damaged by medium and high velocity projectiles is typically many times larger than the diameter of the projectile itself because it has so much energy. And that's because of the type of weapon that it is. This is one reason that those exit wounds are often many times larger than the entrance wound. The energy available for a bullet to cause damage is more of a function of its speed and its mass. And then any information regarding the type of weapon that was used should be relayed to medical control. So here's some of those recognizing problems within trauma patients. This is in your book, Table 24-1. I'll go ahead and let you guys review it better there rather than continuing to talk about it. Blast injuries. Although most blast injuries that we think about are associated with some sort of military conflict, blast injuries are also seen in civilian practices, especially in like mines and shipyards, chemical plants, and then now our big thing since 9/11 is terrorist activities. People who are injured in explosions may be injured by 4 different mechanisms. So you get primary blast injuries. So this is due to the blast itself. Every time you have an explosion, you actually have a pressure wave that's generated. And so this primary pressure wave actually enacts on the body itself, causing the damage. You have secondary blast injuries, and this is damage to the body that results from being struck by flying debris. Excuse me. Tertiary is the victim themselves are thrown and end up striking a stationary object, which can just be as simple as the ground itself. And then quaternary, this is kind of those miscellaneous. So burns, respiratory injury from inhaling toxic gases, crush injuries because the building collapsed, suffocation, poisoning, and then other medical injuries. And then contamination of wounds from environmental, chemical, or toxic substances. And most of your patients are going to have several different types of these at the same time. So tissues that are especially at risk are those that have air in them, such as the middle ear, the lung, the GI tract, because those pressure changes end up causing the gas to expand. The junction between all of the tissue densities are exposed areas such as the head and neck are prone to injury as well. The ear is the most sensitive to blast injuries. The tympanic membrane will rupture at pressures of 5 to 7 pounds per square inch above atmospheric pressure. So it really doesn't take a whole heck of a lot. Pulmonary blast injuries are a result of short-range exposure to the detonation of the explosive, often characterized by lack of visual external visible injuries. Pneumothorax requires emergency needle decompression in the field, and pulmonary edema or fluid in the lungs may end up developing pretty rapidly, and we'll continue on in the next one.